Ladies and gentlemen, students of Bentley College, fellow faculty members and staff, and distinguished guests, I'm delighted to welcome you to the 10th Raytheon Lecture in Business Ethics. My name is Michael Hoffman. I am the Executive Director of the Center for Business Ethics, your Center for Business Ethics, which is now going into its 32nd year here at the college. Today I have the pleasure and honor of introducing to you Mr. Bruce Bodaken, Chairman, President, and Chief Executive Officer of Blue Shield of California, who will deliver a talk entitled The Healthcare Challenge, Balancing Fairness and Business Imperatives. This is a topic of enormous importance, and few people are as qualified as Mr. Bodaken to speak on it. In fact, I had the pleasure of meeting Bruce at his headquarters in San Francisco about a year ago, where I also had the pleasure of talking to the board for about an hour or so. And one thing led to another, and we're delighted to have him here. But before beginning our program, I'd like to remind everyone to turn off his or her cell phones. In fact, like this. I'm turning it. We have a Verizon visiting professor lecturer, as you know, in the spring, and I've often been tempted to sort of do the commercial, which I'm sure you know. Can you hear me now? Sort of commercial. But please turn off your cell phones, or at least put them on vibrate. Before inviting Mr. Bodaken to the podium, I would like to acknowledge the company that has made today's lecture possible, the Raytheon Company. Raytheon is one of the world's leading technology and defense companies. They have been a long-standing supporter of the Center for Business Ethics and one of our most valued partners. One reason for the strength of this partnership has been Raytheon's commitment to creating a strong ethical culture that pervades the company. Let me now spend a moment describing what's ahead in our program for this afternoon, which involves you as well. In order to make this event as engaging as possible, there will be a question and answer session after the formal presentation. Some of you may have to leave for class before Mr. Bodaken has completed his answers to the Q&A session. And if you do have to go off to class, please do so as quietly as possible, because these seats have been designed to make the most maximum noise when you exit. So if you would try to remember to hold them so they don't go boing, that would be great. For those who might want to watch a video recording of today's lecture, please note that Bentley is a proud partner in WGBH's Forum Network, which provides webcasts of selected public lectures from Boston's leading cultural and educational institutions. Mr. Bodaken has kindly allowed us to videotape his lecture in order that it can be included in this collection. If you would like to view the lecture at a later date, because it's going to be so exciting, you may wake up in the middle of the night and say, "Oh my gosh, I want to view that again," then you can find it at www.wgbh.org/forum. I also want to mention that extensive research suggests that listening to a good speech is a stimulus not only to the mind but to the body as well. For this reason, you are all welcome to attend a reception with food and drinks following the lecture. And that will be right out the back door into the forum, which is in the middle of this building on the first floor. There you can also meet our speaker and share your thoughts with him. Before beginning today's lecture, I have a question for everyone present. Are you ready? Yes. All right. My question is this: How are you? While I cannot invite you all to the podium, I think it is safe to assume that most of you are quite well. Otherwise, you would not be attending today's lecture. Here is another safe assumption. At some time in your life, you will not be so well, and you will require the help of a healthcare professional. Those services will be expensive. What are you going to do? No problem, perhaps you think. Maybe for you right now. But for some 47 million Americans without health insurance, about 16% of the population, this is a serious and sometimes catastrophic problem. Healthcare is, without doubt, one of the most important issues facing our nation, one fraught with ethical dilemmas pertaining to the tensions between the demands of business viability and social fairness. Who is to be covered by health insurance? What kind of coverage can we fairly give? What are the circumstances under which coverage should be denied? These are but a few problems that arise in the business ethics of healthcare. To help us face up to this issue of monumental ethical significance, today I have the pleasure of welcoming a highly distinguished leader in the field of healthcare, Mr. Bruce Bodaken, Chairman, President, and CEO of Blue Shield of California. Mr. Bodaken has distinguished himself as a leader in a field in need of leadership. Indicative of this is the fact that he was the first healthcare plan CEO to offer a specific proposal for universal coverage, thereby foreshadowing legislation enacted in Massachusetts in 2006, as well as proposals made by several presidential candidates in the 2007-8 campaign season. I could go on at length about his accomplishments, several of which are listed in the flyers we have distributed around campus. However, I shall restrain myself in singing his well-deserved praise, save to mention one last thing that is particularly dear to my heart. He is a philosopher. And as a fellow philosopher, I had to make sure that you knew that right off the get-go. Having studied philosophy at the undergraduate and graduate levels, he is a model example of what can happen when you set a philosophical mind on practical problems. Enough said. Ladies and gentlemen, it is with great pleasure that I welcome Mr. Bruce Bodaken.
Okay, I think I am sufficiently wired. Thank you very much. That was a very kind introduction. And when Mike asked me to do this, he came out and talked to our board about ethics, compliance issues that he's obviously expert in and distinguished in himself. I talked to our general counsel and said, find out about this thing he's doing, because there are things I'm aware of on the West Coast. I think what is happening here is really unique, and obviously is even got a greater history, having been here, than I thought at first. And I apart from his kind words about my leadership, I think there is clearly a need for, if not more philosophers, more philosophical thought within business around these very important issues. And we face them often unknowingly and often naively. What I'll try to do is take you through a very quick course in how health insurance works and the impacts and implications of exactly the issues that Mike discussed. I do want to take a moment just to round up Mike's comments by mentioning a little bit about our company and a little bit about myself. Just very quickly, there in California, we have consolidated into about 5 major health plans. And it's a very large state, 32 million people, and we have over 3 million of those people enrolled in Blue Shield. But that still makes us the 3rd largest. So it is a very large state with just a very few health insurance programs left. We are one of those. We have a proud and long history, as does Bentley. We were founded 70 years ago by physicians in California. While we've done reasonably well as a health insurance company, nonetheless, day to day, the kinds of challenges in business that we face are ones that I think worry me as much about the impact we have going forward as we have historically. In fact, in some respects, the historical issues are dim ones compared to what we face, primarily around this issue of fairness and distribution. And finally, the personal note. I actually thought in 1970 that I would be sitting out there and you would be over here as hopefully by that time a tenured faculty member of the philosophy department as good as Bentley. When I was in graduate school, I actually had passed my comprehensives in the PhD and started on my dissertation, and ultimately realized that the students I was teaching, of course not the students here at Bentley, but the students I was teaching, Bob and I were just talking about that, there were about 50% that were there because they had to be, because it was a core curriculum, and they didn't have much interest in the subject, and I realized that this was going to be a very difficult time for me to find a job in teaching philosophy, and the fact that at that point in time, at least, students were finding their ways to business schools as though philosophy wasn't important to that. I actually hope there's a renaissance happening, and this kind of program suggests that there ought to be one. So I couldn't be more thrilled to be in this particular audience talking about these subjects. First, I want to talk a little bit about healthcare and healthcare insurance, because sometimes when we talk about these issues, we think they're one, and I think sometimes that confuses us if we're not clear about the terms we use. And there's nothing particularly important about these particular definitions. They just get us on the right track of understanding the subjects we're going to look at. Healthcare, which I know something about, I tell my kids I'm almost a doctor, but the reality is I know a hell of a lot less about health care and the provision of health care in terms of what a practitioner knows and the provision of health insurance. But health care is, as I've defined it here, simply the provision of the kinds of services from getting your teeth cleaned to having open heart surgery and all of the things in between. I'm not particularly, I don't even distinguish here between Western medicine and other forms of medical care. What the issues are that we're going to get into is how we impact healthcare through the model of providing healthcare coverage, which means that you have access, hopefully with some financial support. We have a big public system in this country that is having its challenges, and we have a very large and even larger private system, which is certainly having its challenges. Healthcare insurance, on the other hand, is essentially a guarantee. And there are, of course, some questions, I'm sure, from time to time about whether the guarantee is fulfilled. But the reality is you have a contract with your employer and you, or as an individual have a contract with a company like mine, if you have health insurance, that says we provide payment. In fact, we guarantee payment for certain services as long as within the limits of a contract. Now, the reality is the fairness issue runs through both of these in very significant ways. And I'm not really going to touch on the inequities, if you will, of healthcare provision, although there's plenty to talk about there. I'm really going to focus on health insurance. That's what I know. And there's plenty to talk about. And I'm particularly interested in access to health insurance, those that have good access, those that can afford it, and exactly how that works within the health insurance system. Now, I do want to stay for a minute, though, on the entire system, just to enunciate the point that Mike made earlier. Healthcare is a big deal. It's the largest single segment of the U.S. economy. $2.3 trillion today, almost $4 trillion, it's estimated, in 2015. A friend of mine says that if you trace out the future of healthcare, we'll all be in a nursing home or working in one. There's unfortunately some truth to that. The reality is healthcare gets bigger and bigger as part of the economy. Some of that is good, and some of that is simply the inflation of the cost of healthcare. So per capita, I think you all know we spend more than any other country by far in terms of providing healthcare in this country. Now it's about $8,000 per capita for every man, woman, and child in the U.S. That's about $12,000 a year on a health insurance family of four policy. That would be more in Massachusetts, incidentally, a little less in California, but the reality is, and that is for a reasonable but not comprehensive program, and that is growing at about 7% a year on a compounded annual basis. And that gives you the sense of the infinity of this number if you look out into the future. If it continues to grow at 2 or 3 times the rate of inflation, there will not be enough money to handle the health care issues. Medicare is going to be bankrupt in your lifetime for sure, unless we change the system. So if you're not worried about getting health care the next 30 or 40 or 50 years, believe me, by the time you're Medicare eligible, the question is whether there'll be a system there or not. And certainly what is happening within my industry to deal with some of these issues is to try to manage costs more dearly, but frankly, in a very great regard, what we're doing is skinnying back benefits. So in fact, deductibles are going up, your copays are going up, and that's a way of keeping the price down, but of course that's not improving or increasing your access to health care. So what's the implications of this? Mike mentioned California happens to be the third largest. It's the largest by far in terms of absolute numbers of uninsured in the country by a margin of significance. But as a percentage, we have about 21 to 23% of our state, 1 in 5, do not have health insurance in California. So we have a very large problem. 47 million, as Mike said, in the U.S., about 16%. And I would argue, and would love to talk to you in the Q&A about whether you see national solutions on the horizon, but frankly, I do not. We have lots of discussions with the people in D.C., and for that matter in Sacramento, about what we might do. And there are well-meaning people all over this country that are trying to deal with this issue. But the reality is they run headlong into the economics, and then it's very difficult, especially given the economic times of today, to deal with it. And my hat's off to Massachusetts. It's the single state that has a comprehensive state program of universal coverage. There are lots of other states that have tried things, but there's nothing that really meets Massachusetts in terms of having done more or less the comprehensive job of universal coverage. Now, you're not out of the woods. You have to finance this going into the future, and that's going to be a real issue for the state. And your problem is much smaller. Just to give you one statistic, you had about 300,000 Medicaid. We have 3 million Medicaid members in the Los Angeles County alone. So, the scale for California is very different, but nonetheless, you took on the issue, and I think you took it on well, and I support you in doing whatever you have to do to get it there. And frankly, I want to give a plug for the Blue Cross system here of Massachusetts. I know the CEO well, and they are certainly part of the solution in my view. The thing that we didn't know, or at least we didn't study until about 10 years ago, is that there is a direct relationship between having health care insurance and having a higher health status as an American. And fairly remarkable. The reality is, we know this now, certainly living in California, that in fact millions of people use the emergency room as their private primary care physician's office, because they have no other access except the public emergency room. And that's a very expensive way and not a very effective way to get care. They have more acute conditions because, of course, they're not treated. And so by the time they get into the system, they often find themselves being admitted to hospitals for relatively long periods of time, and often are on a merry-go-round of finding themselves back there. And they don't purchase. Kaiser Family Foundation shows that, in fact, about 50% of the uninsured don't purchase the medication that is prescribed for them. So, of course, what happens is the condition they have gets worse. They're back in the emergency room now for a more acute treatment that is usually treatment that is hospitalized, which raises the cost, and, of course, it's even worse. In fact, mortality for the uninsured is 13% higher or 13% lower, I should say, than for the insured. And it's a pretty remarkable statistic, but they die younger and they are much sicker. Now what I would like to talk about is kind of thinking about how what I've called is the secret of success, and be sure you're taking notes now, because when you're CEO of a health plan, you're going to want to have this. Now, the reality is it couldn't be too big a secret because it's on the screen. But it's not also that much more complicated than this, because these are basic business principles. But it will have an implication for as we go on and think about how does health insurance work to give and provide decent access. First, managing costs competitively. Just like any other business, the health insurance business has to manage its costs at least as well, if not better, than the other guy. And we have two forms of managing our costs. We have the direct cost that we provide, which is primarily administrative. So we process claims, and we take enrollments, and we do a lot of administrative functions around members and ultimately patients. We certainly have to improve the customer experience if we're going to be competitive. And so we're all of us working on that, some degree to better or worse, depending on how well we do. And my own view is that, and I've written a book on management primarily on this point, is that managing and getting and retaining great employees is really the key to 1 and 2. That without great people in our organization, we don't have a chance of doing 1 or 2 well. And the fourth, which is really sometimes a historical legacy as it is for the Blues, we are lucky that we have the kind of reputation we do because of the historical legacy. We're also sometimes don't live up to it, so it can be a challenge. But the reality is Blue Cross Blue Shield, and there are 2 Blue plans, incidentally, in California, Blue Cross of California and Blue Shield of California, so it makes life a little more interesting. But the reality is the brand has been very important in our history, and that's tied ultimately to how we play the brand out in how we service and, in fact, fulfill promises to customers. And some of us do that very well, and some of us struggle at it, but the reality is that is connected to the degree we have public trust. And while health insurance companies are probably just above George Bush's ratings, we do have some degree still trust in certain areas, but clearly we have a lot of work to do as an industry to change. And in fact, part of what I'm describing today and what I hope our industry is hearing as well as you're hearing of the changes we have to make. So the thing I want to talk about, because when we get to trying to describe health insurance access, the thing we have to understand is it does come down to some degree of economics and what you can afford and what we can be in business and successfully provide. So just like any other business, we have to be relentless in managing our administrative costs. We do a pretty good job of that. Some, again, do better than others, and we've been pretty successful in keeping our administrative costs in check, pretty much a little bit lower than our competitors for the most part in California. Provider unit costs, the cost of what it costs us to have you stay in a hospital, for you to be seen in the emergency room, for you to see a primary care physician. It's our responsibility to contract for those services. Unlike Kaiser, that actually provides those services directly, most health insurance in the United States is provided through a network model. That is, we contract for networks that we then provide to you through an insured policy. And we have, not unlike places in Massachusetts, frankly, some very large institutions we deal with. Some that, in fact, are dominant within their area. And that means that we get as good a deal, I think, as anyone, but the reality is those costs are going up. It is not unusual for us to sit down with hospital systems and for them to start a discussion around rate increases in the neighborhood of 30 to 40% a year, which we hopefully get down to something like 10, maybe to 15% a year. But that's about as good as we do, and frankly, no one does it any better in the state of California. So those costs are pressuring, especially those places. Now, we have competition in Southern California, less so in Northern California. Again, Massachusetts is not that different. There are places you have competition. There are places you don't. The third, I can see that we made a little mistake here. The third area of managing our health care costs is around our individual case management. This is probably an area, especially 10 to 15 years ago, which was most controversial around managed care. with physicians saying we don't want to be told by health insurance executives how we should manage care of our patients. To some degree, they were absolutely right. We have changed a lot in that period of time. But in fact, we've also opened up the system to a very great extent, and our costs have gone up. One of the areas that we can do a much better job on, and again, another statistic that is really rather incredible when you think about the healthcare dollar, and you think about as you guys get older, is that 1% of our CalPERS, the state and public employees, have Blue Shield as a provider. 400,000 of our members are in one account, state and public employees. 1% of their members are 30% of their costs. So a few hundred people in that account cost 30% of a very large bill. And so we have taken on a program of actually managing those costs, just that 1%, frankly even less than that 1%, and return to them about $10 to $15 million a year. Most of these people are dying. Most of these people are dying in hospitals until we get there. And the reality is neither do they want to die in a hospital, nor does their family, but they don't have an alternative. We've worked with a provider of intense case care management, for the most part gotten people home, gotten them comfortable both with their pain and also returning to the hospital when they need to be seen. We provide in-home services, both homemaking as well as other kinds of services. And just with that one program alone, we're able to take about $15 million out of the bill of the state of California. But that's managed care, if you will, at its best, and it's not always that good. The last thing that we as health insurance executives very seldom would talk in a public audience, and if my peers are here, I'm sure they are very concerned about what I'm going to say next, which is we balance risk across things that are called risk pools. And we do that by virtue of bringing in and selecting out groups and individuals that we think represent a reasonable risk for our companies to take on. Now, the reality is it works a little bit like this. And some call it risk selection. We call it balancing risk because it's a good euphemism for risk selection or even risk discrimination. The reality is, in California and in some other states, Massachusetts not so much, but in other places around the world, around the U.S. and even around the world, we actually have a fair amount of discretion about who we accept and who we reject. So the reality is, in our individual coverage, where it's most direct, we actually refuse coverage to those that have poor health. If you have hypertension and your historical background you're not going to get coverage with Blue Shield. And frankly, it doesn't matter how much money you have. It's not going to be a matter of you paying us an extra $100 or $1,000 or $10,000 a month. We simply won't cover you. And neither will Blue Cross, and neither will Kaiser, and neither will HealthNet, and neither will United Pacific Care. You simply can't get coverage. We play in a world that is voluntary, and we have the right to actually refuse coverage for poor health. We sometimes accept individuals and ask them to sign something which is called a waiver. So if you have hypertension and you have a problem that is a cardiac problem in the first 2 years of coverage, you actually sign a document that says, I won't have coverage for that condition. And so if you get a $50,000 hospital bill during that first 2 years in which you have individual coverage, that'll be your responsibility, not ours. We can rate up for risks. We have some latitude in some areas to rate up for risks. And so in our small group product, we might charge you an extra 10% if you're a reasonable risk but a little more expensive. And so we underwrite for that. And what is probably most controversial and is the matter of huge lawsuits in California today, I don't know how much play it's getting around the nation. In California, it's huge. We're under the scrutiny, as well as our competitors, for what's called rescinding coverage, which is dropping you because we believe you fraudulently represented your health history. Now, the reason this is controversial is that there is a very recent Gallup survey that says that people believe, about 70% of people in the United States believe that it is okay to lie to your health insurance company to get coverage. And that tells you a little bit about their view of health insurance, and it tells you a little bit about how desperate we are in terms of getting coverage. So the reality is we can do that. So that's how we balance risk. Now the results, as you might imagine, is that healthy people can get coverage. And frankly, they can get coverage that is still pretty cost effective. It's certainly more expensive than it was 10 years ago, and it'll be more expensive 10 years from now. But the people in this room, for the most part, unless you have an unusual condition, come on down. We need your good health in our risk pools. If you're in a large employer or in a public program, you can get health care coverage. And that's true if you're very poor or if you're in a good employer. Certainly Blue Shield of California, we not only provide coverage to our employees, we subsidize our own employees for the coverage they get through our health insurance. For anyone who earns less than $50,000 a year that works at Blue Shield, we actually provide about 50% of the coverage for free. And there's other employers that do the same thing. So we're not, I think we're maybe a little ahead, but not that much. So if you happen to be in one of those groups, and if you happen to be healthy, you're fine. But people that are not, and everyone, as Mike said, it's not at some point in time, do not qualify for individual coverage in California. And unless they qualify for Medicare or Medicaid, that is, if they're old or poor, they can get coverage. If they're reasonable, if they're 45 and they don't have a job, regardless of their income, the reality is they're not going to get health care coverage in California on an individual basis. So the reality of all of this is that health plans, rather than competing on quality and service, compete on how good our actuaries are. How good are we at risk selecting rather than managing risk? And again, you can imagine that a jury of my peers would not be happy with me talking about this, but it's true. Now, I think a lot of what Blue Shield does, I am very proud of. I think we do some things as well as they can be done. But the fact is, this is part of the system. And you might ask, and I think it would be fair to ask now, is this fair? Can this possibly be the right way to do things? Well, it sure doesn't seem fair to exclude people that need it the most. That on the face of it doesn't seem fair. And it doesn't seem fair that some employers and some employees and some individuals are paying their fair share, but we've got some people in the 23% of uninsured in California, about a third of those people earns over $70,000 per year. They can afford health insurance and they have access to health insurance, either through their employer or through a public program, and they choose not to take it. And indeed, my guess is that if you're 22 and you're healthy and you've got some discretionary income, it might not be the first choice on your list for two reasons. One is you don't think you'll need it. And secondly, if you do get a broken leg or something you can't afford, we so far don't let you die on the street in the United States. The reality is you will get health care. It may be in a public system. It may not be exactly the care you wanted, but you will get health care, and people do know that. So there is a set of people in the United States that could afford it, could get it, don't take it. And I think of those folks in the notion of free riders, and I'll talk more about why that is. This represents a huge cost shift that's going on in the United States between public and private payers and between the uninsured and the insured. So what this chart shows is that when we go into contract for a hospital, and they lay out statistics just like this, they wouldn't have 5 years ago, now they're unabashed about it, and they're right. The reality is for every Medicare or Medicaid patient they get paid less than cost. It costs them more to provide the care than they get paid from the federal or state government. And for physicians, it's even worse, at least in the state of California. In the state of California, we have the lowest per capita physician payment in Medicaid in the 50 United States. They get about 50 cents on the dollar if they take Medicaid patients at all. If Medicare, they get a little closer to about 90%. And that's what this shows, is that all hospitals, in this case, are getting paid less. The uninsured don't pay at all. So if you, in fact, have that broken leg and you don't have insurance, you're going to go to an emergency room, you're going to get treatment, and if you don't have any money, the reality is that hospital is simply going to provide charity care. Now, what that means is for those of us who pay, we have to support institutions that also want to have a bottom line. So on average, we pay about 30% more, or on a premium basis, about 15% more. If we had everyone insured today in the United States, all things in, the insurance premium of those who today have coverage would go down, or should go down, I should say, by about 15%. Because now the folks that are getting free care are paying their way, and we'll talk about our proposal, if government programs at least pay their costs, we now have a lot more money in the system so that private individuals and private companies get a better deal. And indeed, that's part of the cost shift that's going on, and that's the free rider effect that I'm talking about. Now, you might say, well, Mr. Big Shot, you know so much about health insurance. You're talking about why this isn't fair. Why don't you do something about it? And this is why we don't. This term adverse selection, that's an actuary's term, but what it really means is if we take on more than the average risk in any population, we obviously have to charge a premium for the risk we're bearing. So if it costs us $1.10 to provide a coverage that we're getting paid for as $1, then we have to raise our rates by about 10% to at least break even. So if we have adverse selection, we raise our rates. And if others are not taking the folks that have poor health status, and we have open doors, two things are going to happen. They're going to have lower prices, and they're going to attract the people that don't have health care problems, which means that we will get adverse risk even to a greater extent, which means that we'll have to raise our prices even more. And then you go into something you never want to go into. If you don't have to know anything about health insurance. If it's called a death spiral, you probably don't want to be around it. And then the actuaries call it a death spiral because the fact of the matter is the risk pool just gets sicker. We raise prices. It gets even sicker still. We raise prices more. And in fact, it's a vicious circle. And so you can never get yourselves out of that. So while I would like to, and in fact we have a foundation that we give $30 to $40 million a year to. As a not-for-profit, we feel like we provide that in some respects in our care, but we have decided to, in fact, provide $30 to $40 million a year to our foundation. They provide actually about half of that money to community care clinics across California. So we're doing in some very small part a piece of this. But the reality is we play the same game as all the other health insurance companies because if we didn't, we'd be out of business. We would attract all of the folks that couldn't get coverage anywhere else, and we'd have to charge a price that would unfortunately drive away those people that are the healthier risk. So that's the way it works. Now in 2002, Mike mentioned, we actually did try to do something about it, but we thought it had to be a systemic change. So we talked about this, not quite so bluntly as the way I've put it to you today. But we think that there is a system, we call it universal coverage, universal responsibility, not that far from what Massachusetts adopted, in which everyone would be eligible, at least for basic benefits, and in fact, if you couldn't afford it, we would actually subsidize that. There would be no restrictions based on health status. We would take all comers. But you would be required, actually, all of you that were thinking about buying that sports car instead of getting health insurance, bad news. The reality is you're going to have to pay for health insurance if you can afford it. And that means through your employer, through individual coverage, or in fact through a public system. We would cover everyone. And this was proposed for California, but the same applies nationally. Now, what is this going to cost? We thought at the time it would cost about $10 to $12 billion. The reality is the 2007 statistics look more like 12 to 14. This is indeed the proposal that Arnold Schwarzenegger sent to the California legislature was almost a mirror image of what we had proposed. Now, it changed in the process, and we didn't get it passed. And that was tough because we were very supportive and we got a long way. But it was about $12 billion for the state of California from a variety of sources. In the U.S., it would be about $80 to $100 billion. That's a lot of money. But I will argue at the end, I think it's money that, in fact, we not only need to spend, we must spend. And we also said we figured we had to talk about how we were going to finance this in California. And that meant to us that you weren't going to get a free lunch. And there are people that will tell you that we can insure everyone in the United States and save money so we don't have to really finance it. I'm here to tell you what I know about the system, what I know about the 7 million people that don't have coverage in California is the system costs will go up, at least for a period of time. And we wanted to be honest about it. And so we said there is no more money, at least in the state of California. We have a $14 billion deficit. So the reality is we've got to fund this. And we felt that probably broad-based funding made sense. We liked the general sales tax, in part because we knew the income tax would be very hard. It's already one of the highest income taxes, state income taxes in the United States. And it was about 0.5%. So the way we could put it to folks is for another half a penny, you could actually get health coverage for every person in California. And we felt that was reasonable. You could also do it other ways. In Maryland, they actually have sales tax on medical services. So when you go to a Maryland hospital, actually the hospital bills the Maryland Blue Plan there, both the charge of the coverage and the sales tax on that coverage. And you could even do it through an income tax or a form of fees, although we thought that politically would be very difficult. So it could be financed. And I've often been asked, if you want to get to this solution, why not just make it a public system? And, in part here, I obviously have a vested interest. I'm the CEO of a private system. But I think, and Mike's met our board, but I would tell you that our mission is around access to good health care. And if our board and I believe that the best way to do that was through a private or a single-payer system, we would promote it, even to our own demise. We simply would, because our mission says we must. If that's the best way to provide access to health care in this country, we've got to promote it. We don't believe that is the case, and there are a couple of reasons for that. First is, while we need to increase access, and I think that's the first order on the agenda, because we, at least in California, have such a high level of uninsurance, we also have to get after costs. Because if we don't, no matter how much we try to make this work, it won't. The costs are outstripping inflation at a rate of 2 to 3 times. That simply has to be turned around. And I personally think, and there are reasons we can get into why I think the private market will actually do that. Also, public systems, at least in California, are affected by the politics of the day. In 1988, I believe I got that right, there was a Northridge earthquake. And in one hospital in Southern California, St. John's Hospital, one person died as a result of, and I'm not sure the details if they fell out of bed, but they were severely injured and died during that quake. One person out of all of the hospitals, out of all of the people in hospitals in California, in Southern California on that day. Within weeks, the California state legislature had made it a state law, and it was signed into law, that every hospital had to be seismically retrofitted, I think at that time by the year 2012. The cost of seismically retrofitting every hospital in California is about $100 billion. Now that would pay for the plan in California that I just prescribed for about 5 or 6 or 7 years to insure everyone. Now, one death is awful for that family and that person, but it weighed against the costs of the reality of whether earthquakes are going to cause massive deaths in hospitals. The reality is it's just not going to happen. We've had plenty of earthquakes, literally hundreds of them in Northern and Southern California. We've not had but one death in all of those earthquakes. But the public system is very much politically motivated, and to undo this, while we've tried to undo it, I don't think it's likely. So we're going to spend that money on something my own view is that I'd much rather spend on insurance coverage. And I would say that while people are very upset with their health insurance, mostly because they don't get claims paid the way they ought to be, or for other reasons, their biggest concern is that they're going to lose it or they can't afford it. So I don't think it's so much about a public-private system as about the nature of the system. Now, I told Bob this story. I went to my the books, of course, that I haven't read in 30 years, to get my copy of John Rawls' A Theory of Justice, and I was so excited that I could open up for it actually a very good reason, which was to give this lecture and talk about the veil of ignorance, which I probably, at least half the audience, if not all of the audience, understands. But John Rawls was in big demand when I was in graduate school, and Robert Nozick as well. And A Theory of Justice had been published within a few years. And I went, and it wasn't there. And believe me, my partner's here, and she was witness to my meltdown because the cover's different. It was that big green cover, and I had notes in the margins, and everything was marked. But anyway, I had to buy a new copy. Not that I would ever forget the notion of the veil of ignorance, which was a notion that John Rawls promoted about how would we get to a just and fair society. And his notion was that we would actually put over ourselves, if you will, as rational, self-interested individuals, not knowing our social position, not knowing where we were going to be once the veil was lifted. And the question is, what would we prescribe behind the veil if I didn't know I was going to be the CEO of a health plan or a student at Bentley College, if I didn't know if I was old or young, if I was black or white, if I didn't know if I was insured or uninsured? What kind of rules would I put around that? And so then I would imagine, not just around healthcare. In fact, I don't think he mentions healthcare throughout the book. He talks about a much broader sense of social justice and comes up with 2 principles of social justice, which I obviously won't go over now. But I thought a fair test would be, is this proposal that I'm suggesting to you today, one, a test that at least John Rawls, he passed away last year, would like to think of? And the Rawlsian test, it seems to me, is when we lifted that veil, I'd ask myself the question, or before I lifted the veil, I'd ask myself the question, what if I don't have health care coverage? What if I can't afford health care coverage? What kind of system would I want operating? Well, one of the things I'd want is I'd want a guarantee of coverage. And this gives us that. So regardless of position, I'd get basic coverage. If I couldn't afford it, I very much might not be able to afford it. I might be a student. And I might, in fact, decide I really do want to teach philosophy, and so I'm actually poor forever. The reality is then I would want a system that if I couldn't afford it, I would want it to be subsidized. And our system does that. And if I wanted to buy up, and this would be a criticism of some public systems, in fact, until recently this was the Canadian system. In fact, providers of care could not provide coverage under a private system in Canada until recently. So if you were a physician or a hospital and wanted to provide public care, which was 80-90% of the care, you couldn't actually participate in private care. So you couldn't buy up. Now, I think, in fact, I don't have a problem if people can afford it to buy up. And in our system, we suggest that you ought to be able to do that, and providers ought to be able to provide that. So our system allows that. How would I get paid for? Well, certainly if I'm rich, I don't want to pay for all of it. But if I'm poor, I certainly don't want to pay an unfair share either. So some kind of broad-based tax seems to make sense. And finally, as a physician or as a hospital, I want to be sure that I at least get my fair share of my costs, if not some modest profit. And again, with the rebalancing of the cost shift that I talked about, it would be a fair system in the sense that at least I would get my costs back from public systems and I would get profit based on a private system. So in summary, I think I meet the Rawlsian test. Fortunately, he's passed away, so he can't judge it, because it might be, in fact, not up to his standards. But, you know, the funny thing and the tragic thing about our current system is it takes fairness on a procedural basis and says, in fact, the system is fair. Under the current rules, not only is Blue Shield doing what's fair, it's doing what the only thing we can do to make it in a system that has voluntary coverage and has a public system the way it's organized. It's fair, in fact, for people not to provide coverage to their employees, and it's fair if I'm an employee and I'm in good health not to take coverage. And I guess, in some sense, some notion of freedom or autonomy, maybe that ought to be the case. But we don't think that about public education. We don't think that about Social Security. We don't let 12-year-olds decide whether or not they are going to get a public education in the United States. We, in fact, mandate it. Why not health insurance? And so I would suggest, in closing, that John Rawls had it right, that, in fact, if we put a test of any kind of notion of social justice, we need a new system. And when I gave the lecture, or actually the proposal at the Commonwealth Club in 2002, and with an audience not too much different than this, I like this quote because, in fact, I think it's a long-term prospect. I am very realistic that we are a distance from the system I propose. The economics work against it. In fact, a lot of people disagree about what's fair, and we have to have those discussions. But we are moving inevitably towards a crisis, and a crisis that only, I think, is going to be resolved by reasonable people of good faith getting together. And I think in my case it really will be a nature of this quote, which is a man is made, at least in start, by discovering the meaning of human life when he plants shade trees under which he knows full well he will never sit. I don't know if I will see universal coverage in my lifetime. My fear is if I don't, you won't see coverage at all. This is not only an issue of fairness, not only an issue of equity, it's an issue of basic human life. And it's one that Blue Shield of California takes seriously. Many other have joined us in that. And there are lots of folks that have joined us in that, but we are still in a minority of making this happen. And again, for some good reasons. We have a big deficit in California. We have a big deficit in the United States. Financing these things are not easy. But we seem to find ways to finance other things that seem to me to be a lot less about human life. And so I would suggest that we look at our priorities, that we reorder those priorities, and we make this, or a system like this, or a system that does the job. We don't even care if it has Blue Shield's name on it or even associated with it. A system that does the job so that we secure coverage for those that need it most and for the rest of it that will need it at some point in our lives. Thank you very much.
We'll take some questions and answers now, and I know those who are leaving are doing so because they need to do that, but I appreciate those who are staying. And we have some people here to bring a microphone to you when you're going to ask the question. Don't be intimidated by that, because that way we can get your question on tape so we can make it a part of the monograph which will come out of this address. So, why don't we begin while certain people do have to leave. Who would like to ask the first question? Oh, could you also say who you are?
Sure. I'm Jack Hansen with the ECOA. Mr. Bodaken, you earlier in your remarks, you commended Massachusetts for its courage or success in inaugurating the universal plan here.
At least initially, yes.
But within weeks or months of the inception of the program, the state is already dealing with the fact that they substantially underestimated the cost of the program. So all of the cost projections, almost right out of the starting gate, were shown to be erroneous. Do you still want to commend us?
Well, yes. Yes, I do. I could not speak to the details of Massachusetts nearly to the level that I can in California because I understand not only the economics but the politics, which I suspect was part of both of to some degree why the assumptions that they made were turned out to be incorrect. The reason I would commend you is that I think doing these things and getting them going, even if they ultimately don't succeed as they are envisioned, they set the foundation for the next opportunity. Now, a complete failure would not do that. And if in fact Massachusetts implodes, as other states that have tried to some degree have, that would be unfortunate. But if in fact you find a way, and frankly you can, it is a matter of finding reordering of the priorities, looking at all of the issues that the state has to face, and deciding that health care is at least number 3 on the list. And if it is, then you will find a way of perhaps adjusting the program, perhaps, maybe not all of the basic, one of the things we took time to do was actually define basic benefits. And we got criticized because our basic benefit plan was relatively skinny. It was a $1,000 deductible, for example. Now, you have more comprehensive benefits in Massachusetts in general than we do in California. So a $1,000 deductible is more of a norm than it is here. But we felt also for cost that you had to be realistic about that. So I would encourage the population, but most certainly the people that make these decisions, to look at ways in which the financing and making sure that we get to a universal system, they deal with the tough issues. And I realize in a political system that there's lots of different voices. But I think the reason I know the reason that I commend Massachusetts is that I believe you got the recipe of the systematic change you have to make right. You either didn't or chose not to look at the hard issues of financing. So that issue is solvable, and it's solvable in one of two ways, either increasing the financing or decreasing the allocation of benefits. And I'd say some combination of both is in order.
Jeff, I see. Oh, yes, and Dwani up there in the back. We'll take this one first.
Helen Meldrum, Associated. Is this on? Okay.
Yes.
I actually have a follow-on to the last inquiry, and that is the main locations that have been providing free care in Massachusetts up until January 1, places like Cambridge Hospital, are experiencing unprecedented cutbacks. So ironically, the people who got their insurance by working at Cambridge Hospital or Boston Medical Center will now lose their jobs and lose their ability to have insurance. Mm-hmm. Do you want to comment on that? Because I actually have a second part.
I guess I don't want to get up too far out of my element. Why are they experiencing unprecedented cutbacks?
Because Cambridge Hospital and Boston Medical used to be able to build a free care pool through the state, and now they cannot. And now that people have choices and they're moving amongst other hospitals with their insurance, what's happening is, without being able to build a free care pool, there's now cutbacks in the
I guess this is why I think the competitive system is one that we should take a hard look at. If, in fact, we don't face those issues, if the hospital next door can, in fact, survive and Cambridge Hospital can't, we've got to face those issues because the costs can't continue to go up at 7% on a compounded annual growth rate. As much as Cambridge Hospital may be a revered institution, and there's plenty in California, they're going to have to face competitive forces and, in fact, find a way to provide coverage at the level set that we think, and it's incidentally, it's at a level in California, and I don't know about here, but it's a level in California that actually is quite a bit higher for public hospitals. This would, in California, increase the allocation of public hospitals considerably because they're getting paid on Medicaid rates that are so significantly less than their costs. Maybe it was reversed here. At any rate, I think, just like I said, Blue Shield should be willing to look first at its mission and then at the effect of the plan. Our mission is to provide access. And if we do that by, in fact, turning ourselves inside out into some kind of public entity, so be it. That's the first responsibility I have as CEO. And I would say to the Cambridge CEO, that's your first responsibility.
Just real briefly, you're talking about Medicaid and Medicare. No, we're talking about the free care pool.
Yeah.
Just people who don't have Medicare or Medicaid were presenting themselves to emergency rooms. And may I just follow up briefly on another comment you made where you said something about being tempted to buy that sports car rather than cover yourself on insurance? You know, the other piece of that is most people who can buy sports cars also have some housing, some other assets, perhaps even an older car. In this state, the person who they got the care from could go and seize whatever assets they had. So I don't think we can be quite that flip about saying somebody might want a sports car instead of covering themselves, because there's still a way in which they're not getting off free in society. You know, those assets will be seized. Yeah,
and again, I can speak to California more than I can Massachusetts. The reality is in California, your care is charity care, and it's simply provided at no expense to the individual who doesn't have assets. People who have assets, I'd say that their responsibility is actually to I mean, the reality is to solve this problem is not to have to deal with that dilemma. To deal with that dilemma by virtue of the way we deal with it in public education, which is that a social good is that people have health care coverage. And so we all need to participate, those of us that are healthy, those of us that are not so healthy, those of us who have means and those of us that do not, on an equal and fair basis. So I'd say that if we use those as first principles, where we'll end up is probably a pretty good place. That does not mean that an individual institution, or an individual health plan in this case, is going to come out on a positive side of the ledger. That'll depend on how good we do what we do, how administratively efficient we are, how good our service is. At least I think.
Dwani, you have someone there?
Yeah, hi. I'm speaking on behalf of a class here, which is a class in histories of drugs trades, and drugs was something, pharmaceuticals was not something that you addressed in your issue, in your talk. And I think my question applies both to the cost of pharmaceuticals and to healthcare more generally. And it's really a challenge to your reasons why a single-payer healthcare system is not the way to go. Arguing from the case of Canada or other, you might be able to hear I come from a state-run healthcare country. The state will actually decide not only, as in Medicare and Medicaid, how much it will reimburse for a particular procedure, but also how much it is willing to pay for a particular drug. And the market operates in that system because companies that cannot provide that service or that drug at that price and make a profit get out of that business. So the companies who remain will make a profit, but the system prevents companies from making more than quite a slim profit because the government is always breathing down their necks. Mm-hmm. Now, I want to ask you, if you were not with such a vested interest, why would you not see that as a better solution?
A couple of reasons. One is the reality is that pharmacy manufacturers are global, not domestic. And what the cost shift I talked about in hospitals is exactly the same thing except more extreme in pharma. Where they don't make money in nationalized insurance areas, they make up in the United States. So the insurance gap, that same gap of 30% is more like 50 to 100% on pharma. So it's not that they're charging the fair amount and making it in those states. In fact, they come to the United States and charge egregious amounts, or fair amounts based on the system, but much higher amounts so they can return about 20% to their investors. There's another way to do that, and one of the ways to do that is, in fact, to make prescription drug coverage part of the basic benefit, again, provide a universal system. And there's no reason, incidentally, within a private system that you can't also look at fixed cost budgets. There's nothing independent of a fixed cost budget within a private system. So if we chose to, and this is something that would be a matter of debate, but if we chose to have Medicare negotiate with pharma to get best pricing, there's no reason why we couldn't do that within a private system. So I think that some of the advantages, and I think there are advantages of the public system, we can take advantage of, but I do worry about people that I know probably in Canada better than anywhere else, because there are actually a few Blue Shield plans in Canada, or Blue Cross plans, I should say, in Canada. Global budgets, in fact, towards the end of the year get used up. And then the queue gets longer, and the ability for them to provide the services that are arguably discretionary, but I'm not sure that we would believe in the United States they're discretionary, like hip replacements, just simply don't get done. I think we can do better than that, and I would argue that a private system can do that and also balance the budget.
Okay, Jeff, over there. Okay. That's fine. And then would you take this person and can't see, but in the middle?
And incidentally, I know I have a vested interest. I mean, so it's hard. Somebody else will have to judge whether I'm being objective.
Hi, John. My name's Sean Carney. I'm a partner at Lambert & Carney Benefits Group, which is a benefit consulting firm down in Fairfield, Connecticut. And like yourself, I struggle every day to help balance the cost of health care for the clients that I have, and I'm very proud to call Bentley one of them. But one of my questions for you, and I was very interested to see, maybe by the lack of omission, was the folks that are in California and states like Texas and states like Florida that are here illegally, and the amount of stress that is putting on you as a provider from a financial standpoint. And then also, maybe as a follow-up to that question, if you were to put on John Rawls' veil of ignorance there with respect to how you handle that population.
That's a very good question. Let me address the first. The one thing in California that is true is that most of the people there, particularly folks coming from Mexico, are in fact employed. And so probably 70% of the people that are like the 70% of the employed population of California, have health insurance by virtue of being in an employer where they have that access to a health insurance plan. So while they're certainly putting some pressure on, if you look at the statistics, the pressure is not particularly different as a result of immigrants than it is just simply because we don't have enough public funding in the system, again, as a result of Medicaid and to some degree Medicare not paying its fair share. So while it's a causal factor, it's not nearly as severe as perhaps in other states, because in fact most of the immigrants are working immigrants and therefore have health care insurance through their employer. In terms of putting the veil ingress over of that issue, I think you're raising a really interesting point. And I think one of the questions that we talked earlier about social responsibility being a global initiative now, if you think about it, corporate social responsibility really has to be global because I heard this statistic, I don't even know if it's true, but I was in a group talking about global warming, and they said that 35% of Los Angeles pollution is due to China going over the ocean. So, you think about that, and you think about the global implications of what we do in this economy, and you might have to start thinking about healthcare that way. So when I put the veil of ignorance on that, if I'm a global citizen, in fact, I come up with the same solution, except I come up with a universal solution. Now, I'm not naive. I don't think Mexico is going to adopt this solution, nor do I think Canada is going to adopt this solution. So I think philosophically, I think it would be the answer would be you'd come up with the same answer. I think the reality is you'd probably come up with a slightly different answer given the realities of that the U.S. system is going to be peculiar to the U.S. economy, to the U.S. demand for convenience, and the demand that, we have, for those of us who are insured, which is most of us still, we have certain expectations of the healthcare system that I don't think we're going to be comfortable foregoing behind a veil of ignorance or when we see the light of day.
Jeff, I promised this person right.
Hello, my name is Claudia Hamburger. I'm from
Sorry, I can't hear.
I don't know if the microphones are working for anyone who's...
Hello, you can hear?
Yeah, that's
No?
better.
Is it working?
It is now.
I'm from Lexington, Mass. I have a question if the insurance companies are looking into, there are so many tests now when pregnant women know if they're going to have a child who is not quite normal, and in reality it's something about having an abortion. Or also at the other end, with end-of-life issues, when someone has a serious illness, when there is absolutely no hope, how long do they get to stay in a hospice situation or what have you? What are the insurance companies doing, your company or any of the others? Because this is putting a huge burden.
Excellent question. I think that's the reason why I distinguish between health care access and access to health care insurance, which I think are different issues. And the issues you raise are fundamental that we're going to have to wrestle with as a society. I don't think they're peculiar to health insurance companies. In fact, I don't think health insurance companies should be making those decisions. I think health insurance companies should be trying to figure out through using both ethicists and thinking about the economics of trying to come up with a solution that is actually representing whatever social contract we're comfortable with. The end-of-life care issues are heartbreaking in one respect, but on the other hand, if you look at the statistics that we know to be true, about 80% of health care is delivered in the last 2 years of your life. Now, you look at that and you kind of ask yourself about distribution of resource and all the problems we're dealing with. See, the seismic retrofitting issue, I can get real clear on. It's one death against billions of dollars, and I don't struggle with that. But when I think about these end-of-life issues, I think they're more difficult to wrestle with. Again, I probably get to a place where I think health insurance companies, in fact, should come up with policies to deal with that, but only with the support of physicians, with providers of care, and ultimately with the voters. Because I don't think if we do it outside that political context, I don't think there's any basis for us to make those what are really fundamental human values-based issues that we're not in a particularly good place. There we have even a stronger vested interest than we do in terms of universal coverage. With respect to the testing, the one thing that is interesting is how much people fear that health insurance companies are going to discriminate based on genetic testing. In fact, at least in California, and I think pretty much nationally, that has already been taken care of. The fact is, while we can exclude someone for a current health issue or a previous health issue that's documented, we cannot discriminate against anyone for any genetic test that's ever been run or ever will be run. That's California state law. I think that's national law. If it's not, it's most certainly California state law. So we can know that your predilection for cancer is 99%. We still have to accept you from a health status standpoint, regardless of that. So I think the genetic testing issues are tough ones. The ones I worry about is these are, again, human life issues, but in fact, proactive mastectomies, where people, again, look at the data and say, my mother, my grandmother, and I think those are very tough issues, both for physicians and individual patients, but I don't think insurance companies should be mucking in that. I don't think that we're wise enough. I don't think we are universally empowered to make those kinds of decisions, nor should we.
Just as a follow-up to my wife's question, and based on the Rawlsian philosophy,
there you go. Okay.
Based on the Rawlsian philosophy, who's got it more right, Hillary or Barack?
I think probably Hillary, because it's a more complete answer. I think Barack can get there, but he needs better advice. I don't think there's anything in Barack's platform that would prevent him from getting to the same solution. I think Hillary's probably closer and also probably pretty realistic about what can be accomplished given what she's been through.
Okay, why don't we take one more question? Okay, good.
Hello. Oh, a little loud there. You've been talking a lot about cost, and one way to lower costs is to get quality right the first time. For example, preventive medicine. And I'd like to get your take on what health insurance companies can do proactively to work with providers and patients to do things like preventive medicine and to monitor health outcomes and to get the quality better, which is a good way of reducing costs.
Yeah, great question, and I'm really pleased to say we're doing a lot. I think others are doing a lot, but at least in California, we got a little bit of a head start in terms of we provide actually a cash incentive to all of our members for taking care of themselves. So if you're a Blue Shield member, you go to our Healthy Lifestyle Rewards website. In fact, you participate in stress management, non-smoking, weight management, whatever program you choose to participate in. You self-report on the beginning, you self-report in the middle, you self-report at the end, and then we look at your claims history. We pay you either way, but we actually have your claims history so we can give you feedback through the web, in fact, whether or not we're seeing the improvement that you're reporting. The next piece of that's the carrot. The next piece of that is the stick. And that will be difficult, but we think important. For our employees, we're instituting this year both. In fact, we're rewarding them they're, of course, members of Blue Shield, so they get the same cash incentive as members of Blue Shield to participate in taking care of themselves. But we will actually create disincentives for our employees that smoke, disincentives for our employees that don't at least enroll in a program if they have a particular condition, if they're overweight or obese, for example. So that is a tougher road to take, and some have done it and actually been taken to court for it. We will start gently, but we think we need to be more aggressive in using both those tools. But your point is well taken. And in fact, if you believe John Wenberg and the studies that he did at Dartmouth, you believe something like 30% of the care that's provided is unnecessary, partly because it's truly unnecessary, it's just additional care, but partly because it could have been prevented. And while I think this movement of managed care started, which I'm not really fond of, that was a term created by insurance companies. I started in a company that was called the Health Maintenance Organization, which I'm more fond of. But it was really truly around preventive care, and we lost our way about 10 years after that started. we really became insurance companies and started to worry less about prevention. And we need to get back to that.
Mr. Bodaken will be out in the forum in just a little bit to perhaps carry on this discussion. And if anyone has an urgent question before they have to leave and cannot come to the forum, I'm sure he would be able to talk with you if you just came forward. Let's give him a great round of applause.